Welcome to Behavioral Health Today, a podcast by Tried Behavioral Health, covering trending topics in behavioral and mental health. This podcast is designed to share unique and relevant topics occurring within the world and our communities and bring them a mental health perspective.
Welcome to Behavioral Health Today. I'm your host, Dr. Graham Taylor. You know, there's such a need for community services in our society today, helping folks address various needs ranging from housing, benefits advocacy, health assessment, to skill building. These areas are particularly essential to the healthy functioning of those transitioning from inpatient care back into their community. But navigating this journey can be a very challenging and often complex process. That's why I'm so pleased to have as our guest today, Mark Graham. Mark is a licensed social worker and the Vice President and Manager of Program Services at Coordinated Behavioral Care. Mark was instrumental in the launch of CBC's Innovative Pathway Home Program, an evidence-based critical time intervention program that effectively transitions individuals from intensive behavioral health settings to the community. The program, in fact, was a 2019 winner of the Heritage Provider Network Healthcare Innovation Award. In addition to his work at CBC, Mark regularly teaches a class on critical time intervention at Hunter College and is taught at the University College Dublin in Ireland. Mark has provided clinical care and management programs in New York City, Manchester, England, and Dublin, Ireland, with a focus on the homeless, people with serious mental health illness, and those with chronic health conditions. I'm so excited to have Mark as our guest with us today as we talk about his Pathway Home Transition Program. Mark, welcome to Behavioral Health Today.
Thank you, Graham. It's a real pleasure to be here.
It is really nice to have you. You know, Mark, I don't always start the podcasts with biographical information, but I am curious as to what in your life brought you to your profession and to community work specifically.
It's an interesting question. I think sometimes you sort of reflect back and wonder how you ended up where you did.
Exactly.
You mentioned in my bio there that I've worked in Ireland, that's where I'm originally from, born and raised. And I spent time in New York, and I actually did my master's in social work in Manchester in England. And I went into social work really thinking that I was going to work with people with physical disabilities. And that was my intent. And then life often throws a spanner in the works. And my first placement in social work school was with the homeless in a homeless drop-in shelter. And through that experience, I came across a lot of individuals struggling with mental health and addiction issues. And it really changed the path of my career, that they were a group of people who I felt did not get the supports and services that they necessarily needed, who had really rich life experiences, and some who had fallen hard times through addiction and other issues, and see how we could work as a society and improve the outcomes for those folks.
I really like what you're talking about there too. My first placement was with the Community Mental Health Center here in Hawaii, where I was there for about 3.5 years. And you're conveying the value that you saw in these folks very quickly, and how their hard times and oftentimes rob them of some of the potential and opportunities that they have. So I really admire that observation and that valuing that comes into this process. As you mentioned, or as I had a chance to talk about in the intro, Pathway Home is a community-based care intervention that offers services to individuals that are in the process of transitioning from an institutional setting back into their communities. Share with us more about Pathways Home and the program that you've created.
Sure. You know, Pathway started as a pilot project in New York City. And it came about. CBC, who I work for, you mentioned my intro, is a membership organization. We're made up of 15 of the largest nonprofits in New York City. And those nonprofits, through CBC, are looking at ways to identify shortcomings in community care provisions and to find ways to improve upon those. And so I was brought on at CBC to start Pathway. As I say, it was a pilot program at the time. And it was geared to support those individuals coming initially from state psychiatric centers, folks who had had long periods of hospitalization, but we had seen firsthand were returning to the community, and somewhere within the community, resources were failing them. And all too often, these folks were returning back to state psychiatric centers or to our community hospitals. And it really sort of gave us pause to think, you know, New York City is very rich in resources. What is amiss for these folks, and what gap in care is occurring when they return back to the community? So Pathway started to be a transitional care program for them. And it was a program with a multidisciplinary approach with nurses, social workers, most importantly, peers and case managers who had the opportunity to connect and engage with someone in a hospital setting and then be there with them as they transition back into the community. And what's a uniqueness about it is it's a 9-month model. So we work with people for a shorter period of time, but working to ensure that they get connected and actively engaged in the community supports that they need.
I really like that. You're talking about, I'd like to hear just a wee bit more. So there's this multidisciplinary approach that comes from multiple angles to really address the needs that can often, if when unaddressed, create these gaps that people fall through, and then the recidivism or relapse before we know it, they're entering back into the facility. Talk about specifically some of the unique aspects that you were intentional about in building in to this program that differentiate it maybe from other programs that are out there trying to provide a similar service. Why is yours working?
You know, it's really interesting. I think some of it comes back to sort of the experience that I've had in the field in 20 years. And we have some very meaningful and great community resources and programming. And I worked for over 5 years managing assertive community treatment teams. And that was a model of care that provides very intensive care to people with severe mental illness in the community. But what I had experienced and seen in New York was that it was becoming overly regulated. There was a lot of requirements placed on the team that you had to see someone a minimum time a month, set amount of time, and that took away from the day-to-day care. And as a clinician, being able to determine who needs my resources today, who needs my support today. And so what we developed with Pathway, and I think where it's unique from other programming, is one, that initial hospital engagement, having an opportunity to meet with a person prior to their discharge back to the community. And to me, why that's important is traditionally a lot of referrals are made on day of discharge. And in very busy hospital units, connect to resources they know, and the person is discharged with a list of programs to go to.
Exactly. So your relationship building even before they get out.
Correct.
Yeah.
We look to see a person at least twice prior to discharge. It enables us to also work with the inpatient team to look about resources local to them in the community. If you consider the community team as the community experts, that we can come in and support those who are working within the hospital to really ensure that the person's getting connected to a program that's close to their home and really meets the needs that they have. And we use that time at the hospital to do something that I call a conversational assessment.
Yes.
And that's an opportunity of just talking like we're talking now and getting to know someone. And so in a lot of ways, like some of the initial things that I talked to a Pathway, to me, it's like going back to basics. Yeah. It's going back to sort of good practice. In a way, it's also innovative because we're doing things that other people are not doing. And when I say a conversational assessment, it's an opportunity just to hear, who is that person? What is their life story? And learning little tidbits from them that you as the worker can do to support them as they move. And some of that can be like, I'll give you a little example. We had a woman who was in a hospital setting and she'd been there for 6 months. And she mentioned her love of reading. We're talking about books. And she goes, but I'm so bored. I've read all that the hospital have on their library trolley twice. And so I was able to leave, go to a bookstore and come back the next day with 2 or 3 books for her.
That's so nice.
Area of interest. And for her, she said to me months later, she goes, I felt like someone actually listened to me. And this was something like normally we go in like, well, what's your big plan? What's your care plan? Or we'll get your benefits, we'll get your housing. But what she wanted was a book. And I think that helped build the engagement that we had with her. And it developed a trust in her that these people actually are listening to me. And so that's why, to me, it's very important. But the conversation is also takes away from doing paperwork. I used to have to go into hospitals with charts and ask people very personal questions on a first visit. Have you ever used drugs? What type of drugs do you use? Have you ever been convicted of a crime? And that, to me, creates an obstacle, a block.
Absolutely.
Because it doesn't connect to you. And so, to me, the conversation assessment is about connection.
I really like that. I can see so very clearly in that relational model It's not about checking a bunch of boxes, getting to know somebody just very personally and intimately, and just saying, I'm interested in who you are. And I can see where, for those coming out of the hospital, that's a scary thing. They're
Correct.
coming back into a world with no one welcoming them. Where are they going to get an Uber back to wherever? And where are they going to go when they get out? And how do they pay for that? And where do they go? And where's the meal going to come from? And we can say, well, here's a list of services. Make the phone call. Well, do I have a quarter to make the phone call? Right. It's such a difficult process. But to have somebody before they even get out come in a couple of times and say, hey, here's who I am and here's what we do. Would you tell me about yourself? I can see where that would reduce for them their anxiety. I would imagine as you're just in that conversational way, and you've got a very nice way about you, and I would imagine those doing the assessment as well have a similar, very personal way, but just identifying their needs based on who they are and making it so very personal. It's got to decrease their anxiety, increase their hopefulness that when I come out, there's something that's going to be able to help me out here. It's going to be very specific to my needs. And what a cool touch too, man. What a nice touch to bring her back a couple of books right there.
It's a small thing. It doesn't really cost much at all. But it enables for a stronger relationship.
Absolutely.
And that therapeutic relationship. I think the other part to what you said there is about that day of going home.
Yes.
And if you have been to New York City, you know how busy the hustle and bustle is. And so the people that we're working with, especially coming from the state PCs, had been in for several years. And even in some of our community hospitals, 6 months. And suddenly you discharge to a street in New York to get on a subway, which are crowded. And for an individual, there's a lack of safety sometimes with that. So we make a point too of accompanying the person home. So on day of discharge, we will be there. We'll use an Uber to bring them back. But we work with our staff for that to be a meaningful intervention, that we do what we call an observational assessment. I will look at how you are socially functioning in the community. Are you able to communicate to the taxi driver your address? I'll walk you down to the deli and see if you are able to purchase the foods that you need. I can get into your apartment and see, I've gone to apartments that are rodent infested, that are not safe, or if you've gone to an apartment where someone doesn't have a bed, you've gone to an apartment where people don't have food. And so being able to observe firsthand enables us to look at some of the social determinants of health that impact and lead people back into our hospital settings. And if we can address those on that first day, you're really taking that first step to ensuring that person isn't returning back into an emergency room in the coming days.
Yeah, I can so appreciate just how that intentional focus and those unique parts you bring to this that are at a relational level, not just, checking the boxes, but at a functional level of what do you need? How are you relating? How are you capable in managing these things? And if you're not, let us step in to help you. If we don't, then there's a gap you're going to go fall through. We'll be right back at the beginning. And what use is that? And I can see where that would lead to a much greater success for those that get out, being able to stay out and, begin to integrate themselves in a successful way back into their lives, in the community, ideally with family maybe, or friendships. Mm-hmm. Do you weave family into these times as well, Mark, if that's available to folks?
I should probably say from the outset, a lot of the individuals we serve are Medicaid recipients. A lot perhaps have been estranged from their family, often perhaps true to their mental illness, but there are a significant proportion that are returning to live with family.
Okay.
And what we've done with the family side of it is to engage the family early with their consent and to have those sort of conversations, to be able to say to the family, like, here's what we can offer. Here's our 24/7 number. You call us if you have a concern about your loved one before you call 911, unless it's a real emergency. But we find a lot of people are concerned because maybe someone's responding to a voice and they don't know how to talk to their loved one through that. Yes. And so we have a little program that we call Us First, and we give it out to the family members. We have little fridge magnets, and it's the on-call number for the team. And I think that has really helped families become participants in that person's care. Yeah. And feel, I think for families to feel that the burden is shared, that they have somewhere to turn to in their community to get support. The families are incredibly important, but to be honest with you, there are other individuals and their resource network might be, as I say, the guy in the deli that they talk to every day, go in to pick up their milk or something, or the guy gives them some free candy bars and something, and that's meaningful to them. And so if I go out and I can't find you, If I know that that's their person, I'll stop by. Have you seen him today? Have you seen Graham? Has he been in for a chat? And when the person goes, yeah, I saw him earlier, you go, okay, well, you do your own little assessment there. How was his mood? You know, so we do try to work on whatever that support network is for that person and get to understand that.
I'm thinking back how you started today on the value that you bring to people that you're working with and the value you see in them. Oftentimes, certain populations in our society don't get a second look. They don't naturally get or receive a value just for who they are. And I'm also thinking about how, given that we often slip into a regulatory assessment process or a regulatory program that checks all the boxes and looks good, it lacks something essential, and that's the relational piece. So you're talking about, instead of being regulatory, this is extremely relational, isn't it? It's away from that regulatory piece into the relational piece, which if I can come alongside you and walk you through some of these things, your chances on reaching your potential are going to be so much greater. I love how you guys in your program use these things to differentiate, not just maybe what other programs are, but likely really is what accounting for your success rate and the lack of likely recidivism of these folks being, readmitted.
Yeah, I'd like to think so. I think some of our program has been a sort of a reaction to the regulatory oversight. I think a little part of just, when we have these teams, we have a flexibility in our team model too. So, maybe it's a very New York thing, but we don't have people come to the office to start their day. They go into the community straight away. We have teams who can return home. We give them laptops. They can write their notes at home. They don't have to come back to an office setting, get tied to it. And so a worker's day is very free. But all the teams have like a text chain that goes. And it's like, I might be up in Harlem today and I went to see Graham, and I'll send a text, I'm in Harlem, and someone will say, would you mind stopping by and seeing John? Right. Because I'm a little concerned about him, but I'm down in downtown Brooklyn. So it's going to take me an hour to get up there. And so they're constantly as a team communicating. And so while each member has a point person on the team, any member of the team can see them.
What a cool model, not just for those that are coming into your program to receive service, but what a great model for those working in your program. Because again, it is relationship based, not just with your fellow practitioners, but it allows you then to go out into the community and connect in that same kind of a way.
Yeah. You raise it like something that we see a lot, unfortunately, in New York is high turnover on community-based teams. Yeah. And we've been fortunate not seeing that. And I do think some of the key is that flexibility we allow to workers, that we put trust in them, and we know that they're doing the work, they're documenting, we hear it through our conversations and our case reviews, but they have the ability, I can see one person once a month and see someone else 10 times a month, based on where my assessment of where the true need is to ensure that person remains stable in the community. And so staff turnover, it also helps a program model because people become very invested in the program. They're familiar with the model. And so there isn't this constant retraining of staff.
Yeah. I'm curious, Mark, about, we talk about outcome measures or success rates, and those are important because it allows us to measure, are we doing right things? I'd like to know both kind of two things. One, what is your outcome measure? What are your success rates? But I'd also be curious as to what are you finding as the areas of vulnerability that you're building your interventions around that tend to take somebody back into a setting, whether through a relapse or a struggle, or so both sides of that, if you would.
Yeah, sure. The outcomes are important and incredibly important. Sure they are. If you want to build on your team's success, if you want to sustain funding, you have to demonstrate that individuals are benefiting from the resource. So we look at 30-day readmission rates. We look at attendance at behavioral health appointments. We do also look at PCP appointments because a lot have physical health issues as well. And what we found when we did the pilot, we were taking people from state PCs, and over the first 9 months, not one person returned. So we had 100% retention in the community. Now, when I say that, I say with a little caveat that there's definitely times where we work to have someone re-hospitalized in a community hospital, because some individuals, the experience of return to community is very traumatic. Hospitalization is traumatic. And so, but if they are readmitted, it's a shorter admission And we're there from day one with them and working with the inpatient team to ensure, like, look, what went amiss the last time and how can we correct that? And then behavioral health appointments, I think we have like roughly a 96% attendance in the first 30 days, which in the behavioral health field is on the high end, which
yes, it is.
Proud of that. But our look at that is also then the second appointment, because sort of research has always shown that if a person makes it to 2 outpatient behavioral health appointments, they are more likely going forward to be able to continue attending. And so we, I said it's a 9-month model. We will make sure that people get to the first 2 or 3.
Yeah.
Then we start to pull back and we're like a safety net for them. So if you were going by yourself today, I'd call the clinic later to check that you made it. And if you didn't make it, I can step back in, but the hopes would be that you have. And then medical wise, over the 9 months we work with them, we have 90% have attended a physical care appointment. So, tracking those is important again on the funding side of it. You had a second part to that question. What is that leads people back?
Right.
A lot, to be honest with you. It's social determinant factors. By that, I mean, I've had people with no heat in their apartment. And their first, and what they've sort of been programmed to, is I'll go to the hospital setting. And unfortunately, at times, I've worked with people over 20 years. Some people have told me, it's like, I know what to tell them to get admitted.
Yeah.
And I feel that's a real shame, because it's like, you can be incredibly resourceful, and there's a lot out here in the community where you could be turning to for that support as well, whether it's a meal, whether it's a warm place to stay. And so that's something that we try to drill in on and focus on. Is what are those social needs? Everything from isolation as well, or someone's Medicaid gets dropped and they can't fill their script.
Yeah.
We do, I think it's unfortunate as a society, place a lot of obstacles to folks that sometimes prevent them getting some of the care that they need, and particularly the medication that they need.
Yeah. I like what you're saying there too. You said earlier that you have part of your program as call me or call us first. Mm-hmm. And I would imagine, and I've worked in some of the settings you're describing too, where they know what to say and they have needs, and it's about getting their needs filled, and met. And you're saying maybe there's a better way, maybe a more longer lasting way we could get your need met rather than just in the short term in a hospitalization, again, to start all over. What if we got that need met together in a way that's going to be a little more sustainable and longer serving you? Mm-hmm. Yeah. So in the short term, call me, call us. Well, call us first. I like that.
And we do provide people with phones that don't have them. So again, we work with a population that, especially those coming from the state PCs. And during COVID, we shipped phones to hospital settings. And so we work with a point person at the hospital. We would leave 10 smartphones there. As person was discharged, we'd be able to give them the phone. We'd be able to do a Zoom call with them, do face-to-face, because COVID obviously was developed as a very in-person program. Yeah. And so COVID obviously puts a spanner in those works, but we have been able to navigate that through technology.
Man, talk about kind of multimodal here and multiple layers and anticipating needs and trying to plan for success. I also like when you're talking about the ways to measure outcomes. We do need outcomes. We do need to demonstrate that what we're doing is working, both to secure funding, but also to refine what we're doing to meet the needs of those that are going to be coming to us. And I like the idea of early indicators, whether it's, what are you doing in 30 days or your appointment attendance, follow-up care physically. That's kind of cool to have those as early indicators, because if those are happening, maybe you get, like you're saying, get to back off just a wee bit, give that person some space, some encouragement, and come in when necessary. Or early identification, early intervention. You can stop it early before something gets, too far down that slippery slope. Correct. You can come in and intervene in a way that kind of prevents that relapse from a very early indication. Those are great observations and catches.
The other thing I think we did, again, with we started at the pilot and we were able to build on it, is allocate some of our operating budget to what we call support dollars or wraparound dollars. And those, when I talked about phones, is where we can tap into to purchase phones. But we have paid for people to return to finish their last year in college, community college credits, the number of credits they needed. We had one gentleman who had a history of being hospitalized around the holidays. And so we were able to, when I talked to him, it was a lot to do with loneliness and being far away from his family. So we were able to pay for a family member to come to New York to spend the holidays with him. And, you pay out whatever, $1,000 in return airfare for the family member. But one day in a New York City hospital is around $1,700.
Exactly.
And that person would have gone in for 2 weeks. So sometimes you have to spend to save.
Agreed. And again, what I'm just struck by over and over in the things you share and the needs that you're identifying, it's that personal approach. Basically, what do you need? Help me understand what your needs are uniquely. Is it loneliness? Okay. Is it you need heating in your apartment? Okay. Do you need whatever it may be? Trying to make it very specific so that those needs don't contribute to something being, causative of their relapse. So two things I'd like to know. One is, how many folks are you servicing, let's say in the context of a year, or how you measure the numbers being served? And if you would, I'd love to hear a little bit about just maybe kind of a hallmark story that would give us a sense of somebody that you've walked through, and kind of what they're doing in their life at this point.
So number-wise, a team serves up to 70 people. But I think probably maybe some of your listeners would be interested. It's an 8-person team. So our caseloads are incredibly low. A social worker might carry a caseload of 1 to 15. Case managers, maybe 1 to 8. Our peers work across the board. So I think, and the importance of that is that the other part of good care is spending time with someone. Yes. And for that time to be quality time. So some of our visits are for several hours. Or sometimes you might spend a whole day with someone. We want to take away this feeling like you're rushed, that you have to get to your next appointment. So we are fortunate to have those sort of small case numbers. And I think it's something that should be advocated for certain programs. I think some of what we have learned over the last 6 years is from the people we've served. And so it's a model that is constantly changing and adapting. And one of the first people that I worked with was a woman who, at the age of 20, whilst unwell, assaulted someone pretty badly and was sent to a forensic hospital. And she was 10 years at the forensic hospital. And she was then transferred to one of the state psychiatric centers where she was for 5 years. And in her time there, she responded incredibly well to treatment. And she became the patient advocate on the unit. I met her, incredibly highly functioning, and a pleasure to work with. So she returned, we found her an apartment in the community. She returned back to the community. I brought her, accompanied her home. And I said to her, your behavioral health appointment's the next day. So I'm going to come and we'll go together. And so we can go through that experience. And she looked at me, she goes, no, I don't need you to come. I can manage this. I have like a skill set. And I said, fine, you should go by yourself. And so the next day, what I talked before about a sort of a safety net, I called the clinic and she didn't make it.
Okay.
And I was shocked, like really sort of profoundly shocked, because a little part of you've been in this field a while, you're like, you have a good read on people. She really seemed genuinely interested in going. So I went up to see her in her apartment building in the Bronx. And when I met her, she was tearful. Oh. And I said, what happened? And she said to me, she goes, I went and I got to the subway. And when she got to subway, she brought a swipe card ticket. And she's up in a busy station in the Bronx and she's trying to swipe herself in. Now, if you've been in New York, it's the tourists. They go too slow. They go too fast. There's a way to swipe that card. And she couldn't get it. And a line formed behind her. And people were like, come on, hurry up. And she said, when I went to hospital, we had tokens and you dropped a token in and worked. And here I am. And she considered herself a native New Yorker, Bronx girl, and I can't even get on the subway. So she laughed. What I learned from it in ways was even those who come across as the most functioning can face obstacles in making it to some of their outpatient appointments that we cannot envision. And I know from being in this field long enough that she would already in the clinic, they've written her off as non-compliant. Oh, she's just one of those state patients. She comes out, she has no interest in being compliant with treatment and stuff like that. Where something as simple as a subway token prevented her. And so we were able to then do some transit training with our peer to build up our confidence about using the subway system.
That's
and
so good.
Appointments. And so I use that, sometimes I think some of the biggest successes to me are small little ones like that. Yes. And what I can learn from it as a clinician to improve the program for other individuals coming out.
You bet. Again, that's that relational piece that says, hey, what happened?
There's another lady that we worked with, and she was someone who was living in the community in a community residence. She was in hospital. She got referred to us. She'd been in the hospital 4 times in 12 months, and each time was in the context of a suicide attempt. And so we met with her. She suffered from a major depressive disorder, and myself and the nurse met with her. And she stabilized when she went to the hospital incredibly quickly on meds. And she said to us, she goes, it's not that I don't want to take meds in the community. I forget. I can't remember. And as someone who takes cholesterol meds, I can totally relate. And so the nurse and the residents didn't want to take her home. They were like, she's too high risk. She needs to be going to a state PC. We can't manage and accommodate her. So our nurse looked into a medication dispensing device. It was a device that he would put the meds in. And if she missed a dose, he would get a text alert and an email alert. And her niece, who was involved in her care, would get the same. And then they could call her and say, you missed a dose. And we knew that if we could test this with her, that if she then became unwell, we'd know it was a choice that she didn't want to take the meds. But she remained out of the hospital for the 9 months we worked with her. And we would get those beeps and text messages. And when we ended, the niece was able to do it. But it goes back to those support dollars. The machine cost $900. And so it was making an investment, an expensive investment, but it was able to save that woman going in out of hospital. It saved her community housing and ultimately perhaps saved her life with her past suicide attempts. So it's this, like I always talk to the staff about being as creative as you can. Yeah. Find something and see if it works. I think we need to constantly look and push the boundaries and not just say, oh, we can't do that.
Folks think, well, that's $900 for a dispensing device here. And $900 is an ambulance ride back to the ER.
Correct.
And then you're talking about another element that we fail to see sometimes. It is traumatic to go into an inpatient setting. Mm-hmm. Inpatient settings are disruptive, challenging places, as well run as they are.
Yes.
They are very traumatic places, let alone the trauma around here I am failing again and all the narrative that gets put into place that makes someone say, maybe I'm just this hopeless case that can't function. And so my home has to be this setting. I can't function outside in the real world. No. And what you're saying is, hey, if it's a failed subway swipe or it's hey, I forgot to take my medication today. Okay, so how do we resolve that without pathologizing it, without ticking it off as non-compliance and, punishing somebody? How do we come alongside you and say, well, let's get creative? I love that. And again, my earlier questions, what sets you guys apart? What differentiates what you're doing that allows the success to be had? So these are some great stories. What I love is just that individual assessment about help me understand what gets you to be successful in the ways that you've got the potential to be successful. So nicely done, Mark.
Oh, thank you.
Yeah, that's good stuff. Hey, I know we're coming to an end of our time today. Is this a model that you can see that could be adaptable to other states in the United States? You're knocking it out of the park, clearly, in New York. How about in other states?
I think easily. I think there's some touch points. No model could be transferred 100% anywhere, and it should always be adapted to a particular region. But small little things like those conversational assessments, that responsiveness, something like you asked before about like seeing people in the hospital. Yeah. The way we got hospital buy-in was that the day a referral came in, we notified that hospital we got it, and we set up a time to go. And so we would drop everything to make sure that we got to the hospital. And so we were able to get the hospitals to do earlier referrals to us. And that responding to them enabled us to get into the hospital. That's something that can be adapted anywhere. I think there's also like the flexibility of allowing your workforce to really determine who is in most need today. Yeah. And again, something that can be done in a way. And then, sometimes some people have asked me about sort of more rural settings, like even upstate New York and stuff. The model remains the same because you're spending time, and it's back to me, it's quality time with a folks. Yes. And so you may be driving there where I'm taking the subway there, but you can bring that person and look about what works for them in their communities that they live.
Really good. Mark, for those that want to find out more about you, the program, give us some resources for them to follow up.
You can come to our website, cbcare.org. Under innovative programs, our Pathway Home program is there. and it will give you a better sense. It will also, we have resources there and we've published a number of articles about our program, but about some of the other innovative work that we are doing. And for those who want to do a little research, we have a psych services article from 2018 that also speaks to the outcomes too. So it doesn't just get down to what I like, which is the personal stuff. It really speaks to some of the outcomes that we've experienced with this program and some of the cost savings for the state.
Fantastic. Well, Mark, you are clearly doing right things. Congratulations on the development of this program and the success of it. That's clearly helping connect resources to patients and patients back into their living situations to live their best life that they have the potential to live. It's been great to have you on the show today, and thanks for what you're doing.
It's been a real pleasure talking to you. Thanks so much.
It's been our pleasure. Thank you. And for those listening in, we always appreciate you being with us, and we'll look forward to seeing you next time on Behavioral Health Today.
We appreciate all the support from our community, and if you like our show, one of the best ways you can support it is by giving us a 5-star rating and leaving a review. Behavioral Health Today is a podcast part of the Triad Behavioral Health Network, all rights reserved.